Thank you for taking time from your busy day to watch this special presentation from the El Paso County Medical Society. I'm Dr. Joel Hendricks, President of the El Paso County Medical Society, and it is my hope that you will find our program of great interest, educational, and informative about the medical care provided by some of our best physicians in our country, right here in the borderland. From all of us at the El Paso County Medical Society, please enjoy tonight's program.
1 in 4 people die of heart disease in the United States. Some of the most common heart issues that we have heard about all day, every day is heart attacks, strokes, coronary artery disease, high blood pressure, AFib, heart valve issues, structural heart disease, and many others. There are always tests that we can do to try to show the signs of heart conditions and be able to treat them before they really get to be a problem. That's what we're going to be speaking about here this evening. This program is underwritten by Tenet, the Hospitals of Providence, and a huge thank you to the El Paso County Medical Society for carrying over this show now for over 26 years. I'm Catherine Berg, and you're tuned in to the El Paso Physician. Hello, thank you again for joining us. Today we're talking about Heart Care 101, common heart conditions and how they are treated. We have with us 2 doctors, 2 interventional cardiologists, one who's a veteran you may recognize, Dr. Edward Assi, who is an interventional cardiologist, and he's also the chief of staff at Sierra Medical Center, which is the Hospitals of Providence with Tenet. And also we have Dr. Byomesh Tripathi, and he is also an interventional cardiologist and new to town. He's been here a whopping 2 months, so we need to take him out for some good Mexican food. But Dr. Assi, let's start with you. Being on this program several times, and again, interventional cardiology, and today we're going to talk about a lot of the basics. We're going to talk about the most common heart conditions that people have. But in general, you're all day, every day. Kind of talk about your role as chief of staff at Sierra Medical Center, as well as your cardiology work.
Hi, thanks for having me. Yeah, so as far as chief of staff, it's just as it says, at the Sierra Medical Center, I basically work with administration and help dealing with issues that come about at the hospital, especially if it has anything to do with mostly the physicians. And I interact with them and helping hopefully solve some problems that come about in the day-to-day aspect of the hospital. But my life is really, I'm just the cardiologist that gets up in the morning and usually hit the day at the hospital and make my rounds, see my patients. Sometimes I'll start off with a procedure that has to be done. And then after I visit the hospital, I head to my office and see a lot of patients throughout the day, again, trying to solve some problems of patients coming in with common heart conditions. Mm-hmm. You know, as far as when the types of problems we see, a lot of patients are presenting with symptoms, you know, chest pain or shortness of breath. Sometimes we're referred for a patient having an abnormal EKG, or another physician may hear a murmur. Mm-hmm. Murmur is just a sound that we appreciate when we use our stethoscopes that can most likely lead to a heart valve problem. That's usually what creates a murmur. So those are, you know, and you had mentioned several things. Atrial fibrillation, we see that as extremely common. Mm-hmm. You know, of course, what everyone is always concerned about when you talk about the heart is clogged arteries. You know, right. Do I have a blockage, Dr. Assi? And how do we figure that out? How do I assess them for that? Mm-hmm.
And so the whole idea, and Dr. Tripathi, I'd like to bring the question to you of interventional cardiology. So you have a cardiologist and you've got just different areas of practice. What is the description of what you do all day, every day in the world of interventional cardiology?
Great. Thanks for having me here. Mm-hmm. So we are cardiologists, first of all, but we get 1 year of special training in interventional cardiology. What that means is that we are trained to treat several heart disorders using catheter wires and needles. The major one is heart attack. I'm sure you have heard of it. We are able to go inside heart with the help of wires and catheters, balloon, and put stents. So this is one of them, but we do a lot of other procedures as well. For example, pacemakers. We do interventional procedures like valvular heart disease fixation. So a lot of these is part of our duty as interventional cardiologists.
And Dr. Assi, as, again, Chief of Staff, but just in general, cardiology, you've been here for quite some time in El Paso.
20 years.
20 whole years. I love it. Congratulations on that.
Thank
so
you.
you've had Mexican food. You can get Dr.
I know
Dr. Tripathi. You can take him out a little bit. But in El Paso, what are some of the most common heart issues that you see here on the border? And is it different from anywhere else?
Actually, so I did training at Baylor Scott and White and the Cleveland Clinic. And I always tell a lot of new physicians coming into the area that El Paso, I think, is very unique. We see a lot of pathologic conditions, and more so than I feel like I got in my training. Just our area, I think, is inundated, unfortunately, with diabetes and chronic kidney disease. And those two disease states really contribute to developing coronary artery disease. And I think that there is a lot of coronary artery disease in El Paso, unfortunately, as well as what we call peripheral vascular disease, which is blockages of other arteries in the body, mostly the lower extremities. So I feel that there is a tremendous amount of disease state here in El Paso, more so than we see sometimes in other areas.
And I know we have a high incidence of diabetes, so that's something that I think is talked about quite a bit. But chronic heart disease, I don't hear an awful lot about that.
You mean kidney disease?
Sorry, kidney disease.
Yeah,
pardon me.
kidney.
Yeah,
well,
so
diabetes puts you at risk for kidney disease as well as heart disease. So
okay. And so when we're looking at, and I do want to talk about peripheral vascular disease, because that's something that is basically, people feel it in the legs. And often when we talk about hearts and cardiology, you think everything's happening up in your chest. But that's not necessarily the case as well. So I'd like to go into that in a little while. Dr. Tripathi, I'd like to, with some of the, I don't want to say easy things to address, but I feel like a lot of people hear about, oh my gosh, I have high blood pressure. Oh my goodness, I have to watch my blood pressure, etc. So I'd like to kind of start relatively basic and something that a lot of people hear about and may have issues with, because that's one of the first things, if you see any doctor, it's like, you know what, I'm going to take your pulse and your blood pressure, and why is that such an important thing?
Right. So high blood pressure, highly prevalent disease in the US and across the globe, actually. And incidence increases with age. And it is estimated that almost 40% of people in the US who are more than 18 years of age have high blood pressure. This is very important because, it can lead to so many problems. It can affect your heart. It can affect your kidneys. It can affect your brain. So that's why we really focus so much on controlling blood pressure if you have it. If you have risk factors, we chase after it, we see if you have the diagnosis, and then we treat it aggressively. Might
you have, and I know nothing's ever easy when it comes to an answer, but what are some reasons people have high blood pressure?
Right. So to answer this question, you have to differentiate between two types of high blood pressures. So first one is called primary hypertension, also known as essential hypertension, and the second one is called secondary hypertension. So let me explain a little bit. So primary hypertension does not have any cause per se, but there are several risk factors that can increase the likelihood of having primary hypertension. So one of them is advanced age. You really can't fix it. In Black people, you can have a high blood pressure, primary hypertension. Also, there are certain lifestyle things. For example, high alcohol intake, high salt intake, physical inactivity. All these can lead to primary hypertension. So, and there's other type called secondary hypertension, where always there is some medical problem that is causing blood pressure to basically, go up. So these are the various reasons, and you have to differentiate before treating them, whether it's primary versus secondary.
So here's a question from a general audience member. If it's something that I understand disease regarding diet, exercise, etc., is there a way to help control your high blood pressure? aside from, I know, again, we've got diabetes, we've got some things that we don't have control over, but how is it that we can control the high blood pressure?
So, you have to differentiate whether it's primary versus secondary.
Right.
If it's a primary high blood pressure, which is present in 90% of the cases, then you start with lifestyle modification. Diet, exercise, low salt diet, low alcohol intake. But if we can control that with lifestyle modification, then we have certain medication that we can use in addition to lifestyle modification. It does not replace lifestyle modification.
Okay. Yeah. And nicely answered on that. And again, just treatments, medications at this point, and you talked about some of the dangers. So I'd like to kind of move into now, and Dr. Assi, you talked about AFib. I'm one of those that has AFib. My heart beats crazy all over the place. I do have a heart valve that doesn't behave, and I feel like over the last, 5-ish years, that I hear a lot of advertising about AFib, or if you have AFib and then, strokes that may or may not be associated with a heart valve issue, et cetera, et cetera, et cetera. So I just feel like this is something that I hear a lot about, but there are so many variations with that. Explain what AFib is to the general common person. What exactly is happening in your heart when you're missing beats or going faster, slower, et cetera?
Sure, of course. So atrial fibrillation is probably the most common abnormal heart rhythm that we run into as we get older, especially over the age of 60. I think of the heart almost like a house. The house, basically, you have bedrooms and you have plumbing and you have electricity. So the heart is basically 4 bedrooms, and those bedrooms have basically fuel lines and electricity to run them, and the electricity runs within the walls of the heart. And in the upper chambers, there's a main electrical generator called the sinus node that fires 60, 80 beats per minute. Well, when you go into atrial fibrillation, the sinus node no longer is functional, and it's a very chaotic arrhythmia that occurs where there is no regular firing from the sinus node. It's coming from multiple areas in the upper bedroom walls that are sometimes going 200 to 300 times a minute, and can cause your heart to become very erratic and fast, which are, the problem with atrial fibrillation is that it causes your heart to go fast, and that's where people become symptomatic, where they feel the palpitations. And then the other major problem with atrial fibrillation is that it predisposes you to stroke. And the reason for that is that when your normal electrical generator is firing, there's contraction of your upper chambers. And so blood moves down to the bottom 2 bedrooms through your valves. Well, with atrial fibrillation, there is no contraction. And the upper chambers are just sitting there basically quivering. And so when you quiver, there's no pumping of blood, and the blood becomes stagnant and then can form a blood clot. And when that blood clot dislodges, it can go to the brain or other parts of the body, but going up to the brain is very common. It's one of the most common causes of stroke that we see in the elderly population. Sometimes people present their first time with a stroke, unfortunately, in the hospital from atrial fibrillation. And a lot of the time when people present to the hospital with a stroke and we look at their EKG and it's a normal rhythm at that time, we still investigate further, because if you're a 70-year-old male or female and you come in with stroke for not a real good reason, a lot of the time it's because you went in and out of atrial fibrillation, and some people are asymptomatic from it. Like, they don't even know. They don't feel the palpitations, the racing heart, or the jump beats. So we investigate for that.
If a person is not having it at the time you are present and investigating, what is the procedure, or how do you find out to see if maybe AFib was the issue? And again, just with my specific self, other than specific, but there are times when I feel it and it lasts, 30 seconds, 40 seconds. And I'm thinking too, for issues of stroke, this happens recurringly, I guess, for whatever time frame that is. What are some of the most common time frames, I guess, when your heart does kind of go crazy? And again, it's that misfiring electricity. And we can talk about ablation too, because I think that's something that could be one of the, I'm assuming at this point, one of the easiest ways of fixing that.
Well, I mean, so the way we investigate it is basically we have to monitor the patient. So while the patient is, let's say, in the hospital, well, they're on a constant typical telemetry monitor so that we can see. But if we don't capture it then the patient really needs to go home with some type of external monitor. They may wear that for a month or so. We also have these really fancy devices now that can be implanted underneath the skin. It's an incision about no more than like 5 millimeters, half a centimeter, that we would make the incision. We slip the device underneath the skin, use a little glue or a stitch to close up the wound, and that monitor connects via Bluetooth to a device that would allow us to transmit and see the type of abnormal rhythm the patient has. And the nice thing about those internal loop recorders is that their battery life is 3 to 4 years.
I remember us talking about this on one of the previous shows, and I think that you showed me on a telephone, on your just smartphone, that you can watch how this is going down.
Yeah.
And how often is that used now? Is that a pretty standard way of...
Very standard.
Okay, very nice.
Yeah, and in fact, all these patients that are coming in with what we call cryptogenic stroke or stroke of unknown reason, a lot of those patients, especially if you have the risk factors, you're 60, 65, 70, 80-year-old with diabetes, hypertension, we know that we have to try and detect it because it changes our treatment for it. And the most common treatment for atrial fibrillation is one, you have to protect yourself from forming a blood clot.
Right.
So a lot of times now everyone's aware of it because you're seeing commercials
for
all these medicines that are used to treat it. So when you have atrial fibrillation, first and foremost, you want to be protected from stroke. So you go on a blood thinner to prevent a stroke from occurring. And then you want to try and prevent the patient from going into AFib or, get them out of it and maintain them out of the abnormal rhythm. And that's usually done with medication. And usually if medication fails, then sometimes we can refer them to our colleagues that are the electrophysiologists that do ablation, basically zapping little circuits in the heart to prevent the atrial fib from coming on.
So I would love for you to talk a little bit about, and Dr. Tripathi, we're going to talk about heart attacks with you. So have fun with that. But we're talking about the electric circuits and the heart. I mean, they really go hand in hand. I know that there's the Heart and Brain Institute or clinic. Talk a little bit about how that communication between the brain and the heart works. And again, it's these nerve endings or this electricity that sends back and forth to the heart. And ablation is basically having that nerve not cut off, but for the most part cut off. Is that correct? Or the electricity?
It's the electricity within the heart. Okay. And I mean, essentially, we don't think about our heart beating. It just does it, right? It's got the electrical circuit that just goes without fail. And when you go into atrial fibrillation, again, the electrical signals have become chaotic. And so what we rely on our colleagues, the electrophysiologists, to do is to go in there, and there are specific areas in the left upper part of the upper chamber of the heart called the pulmonary veins. And the circuits of atrial fibrillation are pretty much, if you can create a little fence around those veins to prevent that electrical signal from being generated there, then you could typically calm it down. And it's, the technology is unbelievable and has progressed throughout the years, and their success rate is really quite good. I mean, probably 80% of the time with ablation, you can fix atrial fibrillation.
We've been doing this program for 26 years, and I remember when I did, some of our first cardiology shows, pacemakers, it was all pacemaker, pacemaker, pacemaker. And this is it, but in a whole different, on steroids type thing.
Yeah.
I would like to talk a little bit about heart attacks, as I know we can get so inundated with cardiology in general, but when we're going to talk about a heart attack, what exactly is happening in the body, like physiologically? And I know there's different types of heart attacks too, but just on a very basic stage, somebody had a heart attack, what does that mean?
So what that means is, like all other organs in body, our heart has those pipes that basically bring the blood from heart itself and provide nutrition and oxygen to the muscles. So during heart attack, what happens is those blood vessels get blocked. And then, as you said, there are different types of heart attacks. So it depends on the degree of blockage of those blood vessels. Yeah.
So when you're looking at the blocking of the vessel, so that means oxygen somewhere along the way is not getting to where it needs to go. So I'm thinking about time frames. If somebody is having a heart attack, and maybe we can it seems that everybody knows it, but not everybody does. If the symptoms of a heart attack are what do you have people look out for?
So most of the times, the symptoms can vary in different patients. It varies by gender as well. Sometimes if a patient has diabetes, you can have very atypical symptoms. But in majority of the patients, if you have a heart attack, patients feel heaviness or pressure over chest. They can be short of breath. Sometimes they can be lightheaded, and they basically sweat profusely during heart attack. So these are the more common symptoms, but it can vary from person to person.
And what should they do? Should they call 911 immediately? Is it something that you mess with? Or you're like, okay, this is going to go away? And I'm just the urgency of the matter.
No, it's very urgent. They should call 911 right away and get checked in the ER.
Okay.
Yeah.
So walk us now through, somebody has called 911. They're in the ambulance. The ambulance is maybe calling ahead to the facility, to the hospital. What is it that's happening once the patient gets to the hospital? How are they going to diagnose what's happening?
Right. So, as an interventional cardiologist, we are always on call 24/7. There's somebody on call for emergencies. So let's say somebody is calling and most likely he has heart attacks. Our paramedics are very trained and they can get EKG right away. And if they basically see that there is heart attack, signs on EKG, they alert the ER right away. Once patient comes to the ER, he gets all the checkups, basically blood work, EKG, and if patient has certain type of heart attack called ST elevation MI, then
Say that slower.
So there is a certain type of heart attack called ST elevation myocardial infarction.
Okay.
So that is one of the dangerous kind of heart attacks. In that case, we don't wait for any labs or anything. ER doctor will directly communicate with one of the interventional cardiologists who is on call and send the EKG. And if the interventional cardiologist confirms that this is STEMI or ST elevation MI, we directly take patient to the cath lab to open the blocked artery.
Okay, so that was going to be my next question, the treatment. So if you're looking at opening an artery, cath lab does what? Is there an MRI that you're looking at? How is it that the doctor is able to see what's physiologically happening with the heart?
Right. So in cath lab, we have a special X-ray machine. And basically what we do is we get access into one of the blood vessels, arteries. With the help of wires and catheters, we go inside the heart, into the blocked blood vessels. And we use different tools like, some contrast, some other medications, and visualize the location of the blockage. Then we cross this blockage with some wires, open that blockage with balloons, and if needed, we put the stent there.
Okay. Yeah. And then recovery time, I guess it's all different with every different patient, correct?
Right, yeah. Most of the times, not more than 48 hours. But let's say if somebody is presenting very late, and he already has or she already has her heart muscles damaged, then in that case, recovery time may be prolonged.
So here's a question that I remember getting a lot, that once you have had a heart attack, are your chances of having an additional one in the future higher?
Yeah, that is correct. Because if you have a heart attack, it means you already have risk factors for the heart attack. So definitely your chances are higher than the normal person who does not have any risk factors.
Okay. Makes sense. You know what we're going to talk about now? Heart valves. One of my favorite subjects.
One of mine too.
Is it really? Oh, thank God. Okay. Because I was the murmur kid. It's like, she's got a murmur. What's up with her? And then it was a click murmur. So I've got a mitral valve that doesn't behave. For the best way it was described to me for years now, it's chronic, but for the most part, benign. Is that where my AFib comes from? Maybe, maybe not. We don't know. But in general, heart valves and replacements, I mean, there have been everything from pig valves to mechanical valves, and then I forgot what other animals are used. But in general, let's talk about a wear and tear. There's structural heart valve issues that can be when you're born or just your body, and then there's a wear and tear of the heart valve. But in general, just take your favorite subject and go to town on how you want to explain heart valve issues.
So going back to my house.
Going back to your house. I love this. The 4-bedroom house. I love that analogy.
To get from one bedroom to another, you have to go through a door.
Right.
And so, the door is your heart valve. It opens and it closes. And those doors can get worn out over time. Those doors separate the chambers of the heart. They can get worn out over time because of wear and tear. I always say, like, the hinges get rusty, and we get problems where the valve or the door won't open well, which can create a major issue, or the door doesn't close well anymore, and you get backward leaking of blood into a chamber where it's not supposed to be seeing the blood during that time of the heart cycle. So the two more common valve conditions that we deal with as we get older, and just like you said, there are conditions that you could be born with that can predispose you to one of your valves or doors wearing out prematurely. So usually when we hear about a aortic valve, which is your main valve that allows blood to exit the heart, and if it starts wearing out in a very young person, like in their 40s and 50s, we usually think that they were born with a malformation of the valve that predisposes them to that condition, such as what we call a bicuspid valve, which is just 2 leaflets instead of there being 3 leaflets. But anyway, aortic stenosis, which is stiffening of the aortic valve where the door won't open well anymore, is a very common condition as we get older. And that's usually from fibrosis and calcium depositing on the valve leaflets, which then again restricts the valve from opening. So aortic stenosis and mitral valve leakage or mitral regurgitation, are where the valve doesn't close well, are 2 of the very most common valve conditions that we deal with in adult life later on in our 70s, 80s, etc. But we've come a long way in the treatment of these valve disorders. You know,
are there symptoms to this? Are there symptoms to valve issues?
Well, the most common symptoms are shortness of breath, fatigue with exertion, aortic stenosis. Because the valve won't open, you can't get blood to the brain. And so if you feel like, you know, one of the more common signs and symptoms I hear about is, Doc, I was carrying my trash up the driveway and I felt like I was going to pass out.
Right, I get that.
So not enough, not enough blood to the brain, and you feel like you're going to black out, have a passing out spell.
Just get lightheaded. That's the way I describe it. I just get lightheaded,
dizzy, and eventually these valve conditions can predispose people to developing heart failure or even sudden cardiac death. So they're very serious, and we've come a long way in the treatment of them. I mean, if you go back, you know, really 12, 15 years ago, the only option for aortic stenosis was surgery.
Right,
You get your chest opened up,
the
surgeon goes in, takes the valve out, and then puts in a tissue valve, which we call a bioprosthetic valve, or a mechanical valve. The problem with mechanical valves is you have to be on lifelong blood thinners, Coumadin, which is the only blood thinner that's indicated for a mechanical valve. And taking those types of blood thinners can create issues of its own. So, you know, within the last 12, 13 years, we've been able to have this great new technology that was developed to avoid people from having open heart surgery. Not that I'm saying surgery is bad, but it gives us another option, especially for our you know, elderly population, that going through open heart surgery would be a very tough procedure to endure. So now we do, there's a technique called TAVR, transcutaneous aortic valve replacement, but we're not removing the old valve, we're actually implanting a new valve. And we use the
alongside the old valve?
It goes inside the patient's own native valve.
So we actually
use the native valve to help anchor and keep our stented valve. It's a big stent with a new tissue valve that's on the inside of it. And your old valve gets kind of pushed out to the side, but it hugs and grabs the stent to keep it in place.
I like that idea. See, the longer I hang out and don't do anything for a while, in 3 or 4 years, maybe I'll come to you and say, hey, I need a replacement somewhere. But so far, it's been good. So we were talking about structural heart disease, and that's where I have TAVR in my notes here. with heart valves that, again, I guess it doesn't matter whether it's something that you're born with or if it's something you get later in life. Bottom line is you still have this procedure that you can do. How long has that been an option, the TAVR option?
Around 12 to 13
Okay,
years.
that really has been that around. Okay. All right.
And we've been doing it now at Sierra Medical Center for the last 3.5 years. We're doing a really good job of it. We've been supported highly by the administration and the hospitals of Providence, and our program is up and running.
Good to know. Yeah. There's always, it's nice to know where you have to go. Dr. Tripathi, I would like to talk about the different things that lead up to coronary artery disease, because that in and of itself, I know that is a bucket of how it can be caused. So coronary artery disease, we hear about it a lot. Again, this is kind of Heart Care 101. Describe what that is to our audience.
So coronary artery disease is basically developing plaque inside the blood vessels of heart.
Developing plaque.
Plaque.
Okay.
Yeah. So what happens is, there are several risk factors that can lead to it. One of them is age itself. So aging population always develops some sort of plaque inside blood vessels. But then you can have additional diseases that can lead to it. For example, diabetes. If it's not controlled, it can lead to progression of coronary artery disease, and you can have heart attack out of that. Then high blood pressure, major risk factor for coronary artery disease. Then some people have high cholesterol or lipids in their blood. So that can also lead to formation of plaque. And unfortunately, sometimes it's just not related to lifestyle. Sometimes it would be genetic. So some people are born with bad genes leading to very high cholesterol in their blood. So these are some of the major risk factors. Other major risk factor that we can modify is cigarette smoking. Very common. So smokers, they have plaque here, in the legs, in the brain, everywhere essentially. So that is one of the major risk factors. And then we can have some minor risk factors as well. As I said before, aging population, there is some rare diseases, for example, like homocystinemia. I mean, you can have high amount of that material in your blood and can cause progression of plaque and coronary artery disease.
So when is it in this course of coronary artery disease that you apply the stent approach? I feel like I hear about that all the time too. When is it in cardiology that you use stents?
So we divide coronary artery disease in two categories essentially. One is stable coronary artery disease, and other is acute coronary syndromes. So what it means is, if somebody has predictable chest pain, for example, it comes only when they are exerting, then they are not called to have a stable coronary artery disease. In such cases, what we do is we try to basically manage their coronary artery disease with medications first, and if that doesn't work, then we can offer them stenting. We can go inside, put a stent, open the blockage. On the other hand, if patient has acute coronary syndromes, which is also known as heart attack, in that case, we have to put a stent.
Okay.
Or patient has to go to surgery depending on what we see inside the blood vessels.
So that would be one of the first basic and fast treatments of a heart attack, of getting everything opened up, for the lack of a better word. Dr. Assi, so there's 50,000 answers to this. Structural heart disease. I always think about this as something that you are born with that may not show up until later in life. What are some of the most common structural heart issues that you've seen in your career?
Well, the valve issues.
Okay.
We lump valve issues as structural heart disease, or performing structural treatment of structural heart disease, and valvular disease falls into that. So as we were talking about aortic stenosis, doing TAVR, that is in the structural heart disease arena. Other things that fall into structural heart disease are things where there's maybe a hole in the upper chamber of the heart called an atrial septal defect or a patent foramen ovale, which has been linked to some people having stroke. So
now I always hear this in the upper chamber. Why is it always that I'm hearing in the upper chamber? Is that common in other chambers too, or is it just?
Well, you can have ventricular septal defects, but they're not as common.
Okay.
We see those more. They can be also something that you're born with.
Okay.
But they don't sneak up on you. Usually the ventricular septal defects are readily heard on exam and addressed, but the hole in the heart that's in the upper chambers, such as an atrial septal defect or a PFO, may never be detected by a physical exam. They typically manifest later in life, whether like a patent foraminal valley, which is just the two upper chambers, the tissue kind of when we're developing inside our mom, the tissue grows together and it's supposed to seal the separation between the two upper chambers. And if that doesn't seal well, then that is what we call a PFO, which can sometimes predispose someone to a stroke. And so the PFO or a part of that septum doesn't heal right or come together, there is a device that can be used to close up the hole. And that can be done surgically with a stitch, or it could be done, again, what we call percutaneously or through the groin, where we go up and put a little device that seals up the hole. So that's part of the structural heart arena as well. Then we have this other device called a Watchman device, which is used to treat structural heart disease. So when we talk about atrial fibrillation again, let's say you have someone that has atrial fibrillation, but they can't take blood thinners to protect themselves from a stroke.
Right.
There's a pouch in the upper chamber of the heart, the upper left room has kind of a little extra pouch that we needed when we were developing, but in adult life, it has really no function other than being a bad part of the heart that predisposes people to stroke and atrial fibrillation, because that's where 90% of a clot that can occur with atrial fibrillation houses. It goes
So
in,
everyone has this pouch?
Everyone
because
has
they
this
had
pouch.
it when they were forming in the womb.
Yep.
I've never heard about this
Yes.
pouch. Tell me about the pouch.
It's called a left atrial appendage,
Okay.
and that appendage is where most of the clot forms when you go into atrial fibrillation.
Huh.
So the Watchman device or an occluder device of the appendage can be put in, again, percutaneously through the groin, going up, and you basically seal off the pouch and close it off so that someone doesn't, if they can't take blood thinners, they have another option. It's a procedure. It's still, it's felt to be second line treatment.
No, but I really love that idea. So that's normally where the clot would start forming.
Yes,
and then
typically.
boom, it's right there by the heart.
Yep.
So once that pouch is closed off, again, the chances of developing then a clot, where would that clot then want to develop? So we're taking chances away there.
Yeah, 90% of your chance of forming
Really?
a clot goes away. And most of the research and literature say it protects you as good as taking blood thinners. So it is something that is available. We're doing it, in the community throughout the Sierra.
And again, you go
Sierra
through the
Medical Center.
groin
Through
to
the
do
groin.
this. Okay, describe, if you don't mind, how that works. And I'd like to talk a little bit too, and it's completely not off the subject, but you were talking about a procedure also going in through the wrist versus the groin. We talked about this a couple of months ago. I'm not exactly sure what it is, but I'd like to go into that too. But the procedures of going through the groin, what arteries you're going through, if you can describe it to the audience, what it is that you're doing as a surgeon.
Sure. Well, when we go radial, that is mainly to look at your heart arteries. I mean, we can do pressure measurements and stuff, but we're mainly going through the wrist artery in order to get to your heart arteries to put a stent in.
Okay.
As Dr. Tripathi was talking about. I mean, that's the majority of the time we go through the radial artery as a conduit to get to our heart arteries so that we can fix that. When we're doing structural things with the heart, such as the Watchman or the TAVR procedures, we're going through our femoral artery, which is the artery, a big artery in the groin, and we can't do it through the wrist because it's too small of an artery.
Okay.
We need a bigger conduit, and the femoral artery is a direct approach to our aorta, and the aorta is the big pipe that comes off the heart. When you see the little model here, this is our aorta, goes all the way down into our belly and then separates into the vessels in the pelvis and into our legs. So we use the femoral artery to get up here to our big aorta in order to deliver a heart valve for such as transcutaneous aortic valve implant TAVR. when we're doing Watchman procedures or PFO closures, we're actually going through the femoral vein. And we use the femoral vein to go to the right side of the heart. And as we've talked about, there's those 2 rooms upstairs and 2 rooms on the bottom. Well, the one room on the right side, you can actually go through the wall that separates those 2 to get to the left upper room. And that left upper room, we're actually going through a wall to get to like the appendage to close it.
No kidding. And so when you're going through the wall, then actually when you leave the wall again, that's another suture that you're doing, but you're getting into that other side that you need to have access to.
Correct.
See, I would love to see a video on this one day. And you as the surgeon too, oh my gosh, I don't even know how to ask this question. How do you see what you're doing? Like, how is the guiding going for you to see what's happening?
We're using ultrasound, and we're using what we call fluoroscopy, which is the X-ray imaging that Dr. Tripathi was mentioning before.
Okay.
You know, the cath lab equipment, fluoroscopy, it's kind of like we use dye and imaging, and we can see where our catheters are. It's like a moving X-ray that allows us to see the different parts of the heart. So we use that in combination with ultrasound.
See, most of us lay people, and please don't laugh, but most of us lay people, we think of different doctor shows and medical shows, and it's like, oh, I've seen that happening before. And I'm thinking, how much is that real, you know? But it is amazing to me how you're able to guide some of that. Dr. Tripathi, I would like to, I see the show often as a show that helps people out prior to big things happening. So I'd love to talk a little bit about lifestyle. You brought up smoking earlier, diet and exercise. In general, we've got a very high diabetic population in El Paso. When we're looking at just trying to keep ourselves healthy, you know, I've got a couple of things on here. Cholesterol is like the big thing. We're talking about plaque. We're talking about developing stuff in our veins and arteries that shouldn't be there. How do you direct your patients to just take better care of themselves? I know this is something I feel like we hear about it all the time, but this is a great platform to talk about that.
Yeah, absolutely. So prevention of this heart disease is a bigger part of our job, right? So we always want to do something that will prevent patient from going to the table. And I always dedicate some time every single visit with patients talking about lifestyle modification, exercise, and diet. So I normally try to talk to them about quitting smoking, right? It's a huge risk factor for coronary artery disease, and certain type of diets. So if patient has, you know, high blood pressure, I talk about DASH diet, which is basically low in sodium, basically low in processed meat, more veggies and fruits.
So you say DASH diet? That's what this is called?
DASH, yeah. It's you know, information is available online.
Okay.
But this is what I talk about. If a patient has coronary artery disease, I always talk about lowering cholesterol in the fats in the diet, right? Including whole grains and beans in the diet. And always talk about cutting down alcohol, or just alcohol in moderation at least. And then a lot of my patients are not super active, right? So, and not everybody can do 50 minutes of cardio every day or so. But I ask them to do at least 40 minutes of brisk walking 4 times a week. If you can do that, this is good. And
40 minutes of brisk walking?
Yeah, 4 times a week.
Okay.
Yeah,
okay.
This should be enough to keep you healthy.
Okay.
So at least do that. If you do more, that's good, but at least do this.
Not smelling the roses on your walk.
Exactly.
Not smelling, get the heartbeat going up a little bit. I was going to say, and there's also that thing about park a little bit farther away than you usually do. Don't fight for that first spot.
Small things, exactly.
You know, small things. I have, again, just from past shows, aspirin used to be such a thing. And I don't know if that is a thing anymore. Like, we talk about blood thinners as a prescription, but is prescribing aspirin, baby aspirin, is that even something that we do anymore? I feel like I haven't heard about that in a long time.
Right.
Thoughts?
So aspirin was a major part of prevention strategy in the past. But then we had several randomized controlled trials, and that have not shown to prevent heart attacks in individuals. So we are staying away, basically going away from prescribing aspirin for primary prevention. What that means is those people who never had a heart attack, and we are trying to prevent heart attack, that's called primary prevention. So we are going away from aspirin. It's not recommended anymore.
Yeah, I was going to say there's a reason I haven't heard about that for a while. Dr. Assi, I'd like to talk about sleep. Specifically, I know we did a program a while back about sleep apnea and just the fact that you're not getting enough oxygen to where it needs to when you have apnea per se. But let's talk a little bit about that with it being a risk factor and finding out if your sleep issues are apnea or not, and maybe describe what that is.
Yeah. Well, obstructive sleep apnea is a very common condition. And I mean, there's definitely, as if you're, depending on your weight, the size of your neck, I mean, those types of things predispose you to developing periods of where you stop breathing. And, chronic sleep apnea predisposes you to stiffening of maybe the lungs, increases the pressure within the lungs. And something that we really hit on the last time we did the show with our sleep specialist was the fact that obstructive sleep apnea has many associated heart-related conditions. Atrial fibrillation comes back. Resistant hypertension. I counsel my patients all the time. They come in, we're treating them for hypertension, and they're just not responding to drug therapy. And then I start talking to them about possibly do they have some of the signs or symptoms, daytime fatigue,
Right.
Falling asleep very easily at rest. And so those types of signs and symptoms may say that they have obstructive sleep apnea. And if you don't treat that, you may continue to have resistant hypertension that isn't responding to medicines or lifestyle modification. So I counsel all my patients, that if they have some of those signs and symptoms, or even if they don't have those symptoms of daytime fatigue, if they have the risk factors for developing sleep apnea and their blood pressure is not well controlled, I typically refer them for a sleep study.
And then once they are diagnosed with sleep apnea, say, and maybe let's describe what that is. So sleep apnea is snoring, heavy snoring, but it's when there is obstruction to the oxygen that gets throughout your body, right? And so if someone is trying to fight that, and I know this is not a sleep show, but maybe describe that, hey, and I say this because so many people are like, oh, my husband snores, oh, my wife snores. So where do they go from here? So they're hearing a little bit about it right now, but how can they fix that?
Well, they need to go get a sleep study. They need to go see a sleep specialist and get evaluated for it. Typically an overnight stay where they're monitored to determine how many spells of no breathing occurs throughout the night, and what do their oxygen levels do throughout the night. And once that's diagnosed by the sleep specialist, then they're prescribed a machine that allows them to get positive airway pressure to prevent the obstruction.
Okay. And let's talk a little bit about obesity. We can talk about that with sleep apnea. We can talk about that in general with cardiology. The reason I'm bringing this up too, there was a study actually this morning that I was listening to. It's like 1 out of every 5 children are now obese, which to me is a staggering statistic. But let's talk about, we were talking about diet and exercise in general, obesity and cardiology in general, interventionally, when we're talking about sleep apnea. This might be a way to say, hey, maybe we can start modifying the way we're eating or watching out for obesity. If you can kind of expand a little bit more on that.
That's right. So, obesity is core problem in so many cardiac disorders. One of them is high blood pressure. So it has been shown that if you lose, 2 kilograms, you are more likely to drop your blood pressure by 5 points, the upper number of the blood pressure. So it's a major problem with high blood pressure. Obese people are more likely to have sleep apnea that can put pressure on lungs and can develop a condition called pulmonary hypertension. That's a very devastating state for the heart too, right? And then obese patients have more likely to have high lipid levels. So definitely this is something that we address every single time a patient comes to our clinic. If they have obesity, we always talk about changing their diet, doing exercise. But these days we have other options too. Let's say if somebody is morbidly obese, then we have different medication that can help you in addition to lifestyle changes. So that's part of our job as well, to discuss and give them options.
And there's something that you can find anywhere now called the BMI calculator, which is the body mass index calculator. And I think that sometimes people are surprised to hear that, oh, I'm not just overweight, I now actually hit the mark for being obese and then morbidly obese. And I think a lot of that too is, in our day and age, somebody being overweight has become the norm, unfortunately. And so again, if you just look up body mass index almost on anything, you will have a calculator of how you can diagnose that.
Exactly.
We are kind of at a 10-minute point before this program wraps up. And I usually like to stop all the questions that I have and ask both of you what it is that, for example, when you're driving over here tonight, there are certain things I want to make sure that I talk about, and we may have not touched base on it yet, or if there's something that we want to reiterate. And Dr. Assi, since you're our veteran, I'm going to start with you, but just think of some things that that you deal with every day that you think the audience should know about. Dr. Assi, what are your thoughts?
Oh,
I
need, well, and I need to touch base again on coronary artery disease.
Okay,
because
good.
I think it would be, I think if someone could follow me around just take this past week, the amount of patients that we had to, one, use stents on, send to open heart surgery for quadruple, triple bypasses, and the patient population, it's not that it's happening later in life. We're seeing it earlier in life. We're seeing 50-year-olds going to open heart surgery with multi-vessel disease, which means that not just one artery is blocked, but all of your major arteries have major blockages, and we can't put 10 stents in you to fix everything. We have to send people to typically open heart surgery. And, just the other day, the spouse of one of my patients says, how do we fix this? How do we stop this?
Right, great question.
How do I become aware of this? And when everything is about taking care of yourself early, preventing something like this from happening later on in life. Eat right, avoid obesity. Obesity is an issue.
It's an epidemic. It
is
really
an epidemic.
is. Yeah.
And, taking those lifestyle measures early to try and prevent something, change your lifestyle right now. If you smoke or if you're eating poorly on a day-to-day basis. And the warning signs, when you start having chest discomfort, don't take it lightly. If it's unusual, if it's new, go in and get evaluated. There is nothing that anyone's ever going to say, oh, you overreacted.
Right.
Get it taken care of. Time is muscle.
Right.
We're on the clock. Anytime that someone is having a heart attack, we are, as that EMS, El Paso Fire, when they get to your house and they get that first EKG, the clock is ticking right then and there to get that patient to the heart lab to get the artery opened up. So it is a major issue if you prolong it, because the more time you wait with those symptoms, you're damaging more and more heart muscle. So I just, I don't know that we could ever emphasize that topic enough.
So here's a question of someone who may be really getting the message for the first time. They've probably heard it, they're listening to this program, and they're thinking, okay, I have had shortness of breath, I know I'm overweight, I know, et cetera, et cetera, et cetera. So what do they do now? Do they call someone at Hospitals at Providence? Do they find out where Dr. Assi is and give him a call? In general, what is it that you can do and feel Dr. Tripathi come in and say, okay, this is what you do now. I need to see someone, and who is it that they are? Say they don't have a primary doctor. Obviously, the answer would be your primary doctor. What do they do now?
So, I would basically categorize the symptoms based on whether it's acute, meaning somebody is doing normally and then all of a sudden they have shortness of breath, or they have acute chest pain, meaning they're doing normally and now they have, crushing chest pain. In those cases, I would not want them to wait to see their primary care doctor. They should just call 911 or somebody should drive them to go to the ER to get things checked, because there are several disorders related to heart or lungs that can cause these problems. On the other hand, if somebody is having these slow progression of symptoms.
Right,
then,
and that's more what I'm talking about. Just someone who's like, you know what, I need to get something checked.
Yeah, then either they can go to primary care doctor, get the referral done, get the initial workup done with PCP, and then get referral to us, or they can just call our clinic and get appointment set up.
So that's a question. So calling your clinic to get an appointment set up,
right.
They can just call the Hospitals of Providence Heart Clinic, Heart and Brain Clinic?
I believe it's different for different ones. But for my clinic, we have direct number. They can just call, and there's a staff that can help them schedule the clinic. Yeah.
Look up Center of the Heart.
There we go.
The Hospitals of Providence Center of the Heart. We have a great group of physicians, new physicians. Dr. Tripathi is extremely well trained. We're all going to be ready and willing to help take care of El Paso.
And that's really what I'm looking for, just the first line of defense. Like, this is what I need to do. I need to call. So Hospitals of Providence, Center of the Heart, just telephone them and say, hey, I'd like to make an appointment. I want somebody to see me. Help me out.
Absolutely.
Dr. Tripathi, so you being new to this program, is there anything that you'd like to talk about before we start wrapping up? Anything that you have a passion about in your world of interventional cardiology?
Right. So I'm an interventional cardiologist, but I said before, I'm a cardiologist too. So I see a lot of patients with heart failure in my clinic. And I see very less.
And when you say heart failure, that's also loaded. What does heart failure mean to you?
Right. So heart failure is broadly categorized into two groups. One, where the heart muscle is weak, right? It's not functioning to the full capacity. And the other type of heart failure is where heart muscle is stiff. It's not relaxing. So there are so many treatments available. So by the way, heart failure patients have very high mortality in 5 years. And I see a lot of patients, they haven't been treated optimally because now we have lifesaver medications. They can be on that and that can increase their life. So I want to spread more education about heart failure. I'm very passionate about treating heart failure too, because now we have so many options. So I think this is a separate topic of its own. But I would just want to say—
So we have a couple of minutes. Talk about some of the options to treat heart failure.
Exactly. So we have medications called GDMTs, also known as goal-directed medical therapies. These were medications not available 10 years back. Now we have at least 5 categories of those medications. I see only 10 to 20% patients who come to my clinic, they are on optimal medical therapy.
We've been here discussing Heart Care 101, common heart conditions, and how they are treated. I want to say thank you so much to Tenet, the Hospitals of Providence, for underwriting the show. And always a huge thank you to the El Paso County Medical Society and all the doctors that come on the show and have been doing the show for so many years. You can watch the show again on pbselpaso.org. You can also catch it on EPCMS, which is the El Paso County Medical Society, and that's .com. And good old-fashioned YouTube, which is not so old-fashioned, but in the last 10 years or so, you can go to youtube.com and literally type in The El Paso Physician, and you can look on there and see whatever the topic is that you are interested in. If you want to talk about cardiology, Heart Care 101, if you want to talk about orthopedics, etc., just type it in there, and there are years worth of programs that you will see on there that you'll be able to re-access, which is always a great thing. Thanks for tuning in. I'm Catherine Berg, and this has been The El Paso Physician.